fortunate to have another local from Brisbane this time, Dr. Adam Irwin, who works at the Hospital. He's an NHMRC Graduate Leadership Fellow and lecturer in Paediatric ID at the University of Queensland and the hospital. His research interests include early recognition of invasive infections and sepsis. I guess to that end, he's the medical co-chair of the Queensland Paediatric Sepsis Program, which is recently awarded a Global Sepsis Alliance Award, which is fantastic work. So I will hand over to Adam. Thank you very much for joining us today, Adam.
Thanks, Sean. Can I just confirm you can hear me? And I will share my slides. So can you confirm that you can see those as well?
So far, yeah.
Great, excellent.
If you put them in presenter mode, should be okay.
Okay, there we go.
Fantastic, thanks.
Thanks for the introduction, and thanks, Sean, for the invitation to speak. And in fact, it's great to follow on from Chris, because I think Chris's talk has set the scene fantastically well. And I was given a slightly more, hopefully, discursive title, which reflects, I think, some of the challenges of how we might manage this increasing burden of multi-drug resistant gram-negative infections in urinary infections in children, and particularly in relation to hospital in the home or OPAT. I don't have any declarations relevant to this talk. And a thing that I always do when I'm presenting to a mixed audience like that is just draw the distinction between children and adults. And, Christopher started to hint at that. So this is, I'm led to believe, what your patients look like in adult practice, showing off their medals and their travel history. And these are the kinds of patients that I'm used to seeing with their slightly questionable rugby league preferences. And just like Christopher mentioned, urinary tract infections in children are exceedingly common. An estimated 2 to 8% of preschool children will experience a UTI, girls somewhat more than boys. But in early life, in infancy in particular, that variation is less pronounced. Both boys and girls experience febrile urinary tract infections, assumed to be upper urinary tract infections in early life. And while images like the one on the right make for nice pictures on a PowerPoint slide, often these children are systemically unwell with high fever and a presumed systemic infection. And so naturally then, as these children and infants present to the emergency department, they're one of the most common serious bacterial infections that cause febrile illnesses in children. This flowchart from a large prospective study, which is now 10 years old or more, from Sydney, of all febrile children under the age of 5 presenting to the emergency department there, indicated that urinary tract infections were the most common serious bacterial infection, accounting for around about 3% of all febrile presentations. And a significant number of these would have been admitted to hospital for intravenous antibiotic therapy. And this diagram here reflects a similar kind of breakdown. This is a study of 1,100 children that I performed in Liverpool in the UK of febrile children presenting to the emergency department, a slightly different group to the previous slide, in that this was a group that was selected out for biomarker evaluation. So a group considered to be at risk of serious bacterial infection. And again, in this group, the second most common serious bacterial infection identified were urinary tract infections. Around about 6% of all of the children in this study had a urinary tract infection, all of whom were admitted to hospital with a median length of stay of 3 days. These were children 2 to 3, with an average of 2 or 3 years of age, so young children. And while a third of these had comorbidities, that means that 2/3 had none. So urinary tract infection in children causes a significant burden of disease and causes significant admission for intravenous therapy. But there's no, and there's no good evidence to support that, but that's the current paradigm. And so if we've established that urinary tract infection causes a significant burden of disease in children and causes admission to hospital with intravenous therapy, then we may have established that there could be a role for hospital in the home and outpatient parenteral therapy in avoiding admission to hospital. And so there are a few data to support that in children, but this fairly recent publication from Penelope Bryant's group at the Royal Children's in Melbourne examined their data over 4 years from their hospital in the home, looking at children who are admitted directly to the hospital in the home from the emergency department with a diagnosis of UTI. And this group was a group that appeared unwell in the ED. A significant proportion of them received intravenous fluids. 8 of the 62 received an antiemetic, so were presumably vomiting. And the majority went home without complication. Less than 10% were readmitted, represented to the emergency department, and of those, around only 4 were admitted for a hospital stay of more than 24 hours. So the experience of this group down in Melbourne was that admission to outpatient parenteral therapy for UTI from the emergency department was safe and effective. What I would point out, though, is that while there were 62 patients admitted for the management of UTI to HITH from the emergency department here, there were 600 over the same period who were admitted to hospital with a UTI. And so there's still a significant burden of disease that's being admitted to hospitals for intravenous, inpatient intravenous therapy. What you'll notice from this table in the bottom right is that the age of those children that were admitted to hospital was younger. You were much more likely to be admitted to hospital if you were younger. So what I was hoping to do in this talk was to discuss how the management of UTI might fit with the general principles of outpatient therapy. And so what I'd like to do is consider throughout the general principles of OPAT or Paediatric OPAT. Do we have an appropriate clinical indication? And I think that the fact that there's a significant number of children who are admitted to hospital for intravenous antibiotics for UTI, and that we've some data to support the fact that they can be safely managed at home with intravenous antibiotics, suggests that this is an appropriate clinical indication. But I fully support Chris's assertion that, in fact, many of these children might appropriately be managed with oral antibiotics. And so before a decision is taken to start a child on OPAT, we really need to consider whether IV therapy is necessary. Is there the necessary social support in the home in order to safely undertake the HITH care? And do we have safe and effective therapy for this clinical indication? Do we have a clinical guideline in place that supports the use of intravenous therapy for this indication? And not only that, but can the HITH guideline support antimicrobial stewardship principles? So what we want to avoid is the possibility that the HITH pathway provides a mechanism to continue intravenous therapy unnecessarily. And the way in which it's proposed we do that is to ensure that there's appropriate specialist input with pediatrics, pediatric infectious diseases, along with antimicrobial stewardship pharmacy, in order to ensure that there's a regular review of the necessity of ongoing intravenous therapy an appropriate IV to oral switch when necessary. And so indeed, that's the HITH model that we have at Children's Health Queensland. Our model is a home care model rather than an ambulatory care model. We have leadership from a consultant paediatrician, specialist, pediatric infectious diseases input, along with expert antimicrobial stewardship pharmacy input. We have specialist nurses that are dedicated to the HITH team, and we have access to a specialist intravenous access team. And on the right-hand side, you'll see the flow chart that's followed for children, both from the emergency department and for continuation of IV therapy from the hospital wards. First of all, there's a consideration of whether the social circumstances are appropriate for HITH, whether parents can maintain appropriate contact with the HITH team. And then there's a flow chart through which we can decide whether or not intravenous therapy is indeed necessary, and if so, whether they fit the criteria for HITH treatment. Sean, I was supposed to hit my timer when I started this talk, and I realized that I did it about 5 minutes late. Where are we up to, and how much time do I have?
Oh, you're fine, Adam. We started a bit early anyway, so
great.
Crack on.
Crack on. Good. So so then that's I think that's the case for OPAT management, HITH management of UTI in children from the emergency department, most of whom have straightforward infections, but increasingly what we're asked to manage, and the reason why I was interested to give this talk is increasingly what we're asked to manage is those children who have complex comorbidities, possibly a history of recurrent infections and past resistant infections, for whom we're being asked to support hospital avoidance. And so this is a somewhat fictionalized case of a 5-year-old girl with acute lymphoblastic leukemia who had a really extensive and pretty awful inpatient stay through the course of 2019, with these weeks and weeks and weeks of fever, and during the course of this prolonged fever, weeks and weeks of neutropenia. So a prolonged febrile neutropenic episode with extensive mucositis, typhlitis. During the course of this admission, had an Enterobacter cloacae line-associated bloodstream infection, and unsurprisingly had this really significant antimicrobial exposure. So weeks of Piptazobactam with or without vancomycin, a prolonged period of meropenem for treatment of the Enterobacter bloodstream infection, and then in August we cultured a carbapenem-resistant Pseudomonas in a urine sample, but not at the time a significant infection. Some months later, though, when this child was much better, she presented with fever and a proven UTI with this multi-drug resistant, difficult to treat Pseudomonas aeruginosa with resistance to ceftazidime, Piptaz, Kefpime, and carbapenems, although it retained susceptibility to gentamicin, fortunately, and that was our treatment option. And so, just like Chris highlighted, antimicrobial resistance in gram-negatives is one of the great global health issues of our age, projected to cause 10 million deaths annually by 2050. And these multi-drug resistant gram-negatives are some of the most important priority pathogens for which we need new antimicrobials. And there has been some progress in developing new antimicrobials for carbapenem-resistant Acinetobacter, Pseudomonas, and Enterobacterales over the last decade. But really for us in pediatric practice, it's challenging to see how we can introduce those agents. just for ease, when we're talking about multi-drug resistance, we're generally referring to non-susceptibility to more than one agent in at least 3 antimicrobial categories. And those are the definitions of extensively and pan-drug resistant infections. And the mechanisms through which gram-negatives might achieve antimicrobial resistance are illustrated by this really lovely review by John Iredale. And those mechanisms include, for example, a reduction in porin numbers or mutations in porins on the surface of the cell, enzymes that will inactivate or modify the antimicrobials like beta-lactamases or antimicrobial modifying enzymes, or pumps such as efflux pumps. And so there are a number of different mechanisms through which gram-negatives will acquire resistance to our antimicrobials. So then another very quick case, we've had the case of a child who's in hospital for a prolonged period with a significant antimicrobial exposure who acquires a multi-drug resistant Pseudomonas aeruginosa infection. And in this case, this was a 4-year-old girl, again with ALL, so under the treatment of the oncologists, with a history of travel and hospital exposure in Singapore, who during her maintenance therapy, we cultured a carbapenem-resistant E. coli in a urine sample, which was found to be an MDM producer. And the only treatment we had available to us was colistin. And so not only are we seeing the spread of antimicrobial resistance through antimicrobial exposure and selection, but we know that we can see highly resistant organisms through this global dissemination of highly resistant clones. And so the question we're asking ourselves in pediatrics, much like the question that Christopher was posing earlier, is what should we do and on what basis? And these questions are particularly challenging for us in pediatrics, where we have very few data to guide us, particularly on the newer agents for multi-drug resistant and extensively drug resistant organisms. But what we do have over the last couple of years, and indeed on the right-hand side, the document that I'm referring to there was published just this last week or so, a consensus guidelines that make recommendations for the most appropriate treatment of infections according to both the source of the infection and the mechanism of resistance. And so ESBL Enterobacterales are not necessarily multi-drug resistant, but frequently they are. The vast majority of urinary tract infections are E. coli, and E. coli will often be carrying a number of different resistance mechanisms. And our first line recommendation for the treatment of ESBL Enterobacterales would still be carbapenems, with the possibility of using quinolones or Bactrim. But for those that carry a carbapenemase, it becomes much more challenging, and the IDSA recommendations all refer to newer beta-lactam, beta-lactamase inhibitors, or cefiderocol, with alternatives, assuming that the organism is susceptible in vitro, alternatives of aminoglycosides, tigecycline or colistin. So we're frequently faced with quite challenging treatment decisions in a case like the one I presented earlier with an NDM E. coli. There is a flow chart as part of these guidelines that helps you to work through the most appropriate therapy for a carbapenem-resistant Enterobacterales, depending upon the meropenem MIC in vitro and the presence or absence of a carbapenemase enzyme. And the IDSA guidance also makes recommendations for the difficult to treat Pseudomonas infections, much like the one that was presented earlier. But many of these agents are relatively new. They may have received a license for treatment in adults, but we're only really starting to get data on how we might use these in children. So some of those beta-lactam, beta-lactamase inhibitors that I've just mentioned, like ceftolozane, tazobactam, keftaz, avibactam, merovabor, we still have very few data to support their use in children. Cefiderocol is a drug of considerable interest to many of us, but really it's only just we're only just in the process of gathering phase 2 data for cefiderocol in children. And that's just to give you an indication of some of those in tabular form, and to give you some idea of how much data we have to support dosing. We're generally looking at a few dozen children that have been so far included in published data sets that would inform how we dose these drugs in children. And what I would just refer to the fact that Aztreonam's been around for a long time, and this paper that gave us some PK data for Aztreonam was actually published in 1984. Aztreonam is a drug that we are able to use on HITH, although we haven't used it very often in the years that I've been here at Queensland Children's. And so it may be that that's a potential solution for us as we manage some of these more challenging infections in an outpatient setting. So to go back to those general principles that I was referring to earlier, first of all, there's the question as to whether or not this is an appropriate clinical indication. If we're agreed that a complicated UTI and a febrile UTI may be an appropriate indication for outpatient therapy, and that hospital avoidance is attractive, then the question is whether or not IV therapy is necessary. And if we answer that question with a yes, the question then might be, is it really necessary? Do we really need to try and send this child home on intravenous therapy? The other questions that we might ask is, if we're faced with a multi-drug resistant gram-negative, do we have an effective drug for which we have dosing guidance in this child? And if so, do we know how we're going to monitor this drug in an outpatient setting? Does it require therapeutic drug monitoring? What regular investigations do we need to do to ensure the safe care of this child in an outpatient setting? And all of these considerations also need to take account of whether or not the drug that we're proposing to use in this drug-resistant infection is stable in the way that we want to administer it in the outpatient setting. We have explored, and with some success, the use of alternative infusion devices, things like ceftazidime, with parental involvement in administering some doses of a drug, and that might increase our therapeutic options. We need to, of course, consider all drug-drug interactions, and the group of children in whom we might be keen to avoid hospital admission are often the children with many comorbidities. They may have significant polypharmacy, and they may indeed be receiving parenteral nutrition, all of which will make administration of intravenous antimicrobials and infusions of antimicrobials challenging. And then we need to ensure, of course, that we can perform regular safety monitoring in the home, that we've got appropriate IV access for the drug that we're proposing to use, be that a peripheral or a midline catheter, or a PICC line for more definitive and longer term access. And finally, of course, we need to consider whether there's a need for therapeutic drug monitoring. So my conclusion would be that I think there is a clinical case to use pediatric outpatient antimicrobial therapy for UTI, and I think there's a significant opportunity to reduce hospital admission and the burden of the number of children who are being admitted to hospital for this indication. But we are increasingly seeing resistant and multi-drug resistant infections, and those who are more likely to get resistant infections are those with complex comorbidities in whom we may be keen to avoid hospital admission. And there are newer treatment options available to us, but it's challenging enough knowing how to use them and dose them in an inpatient setting. We have few dosing data available to us in children, and their suitability for HITH is so far mostly untested. And I'd just like to thank the HITH team with whom I work at Children's Health Queensland, and also Nicolette Graham, who's always a source of fantastic guidance and advice. Thank you.
Very much, Adam. That was a fantastic talk. Even though I don't work in PEDS, I found that very useful.